Welcome everybody to our webinar named Metabolic Syndrome and Cardiovascular Disease. I will just make a short introduction of our chair and speakers and hand over to Professor Dr. Tsarouas. This is our timetable for today. I want to say that the questions will be asked after every presentation, and you have the Q&A section, and please address your questions there, and our speakers will try and answer them all if possible. Okay, so here is our chair, Professor Dr. Konstantinos Tsarouas, graduate of Medical Aristotle University of Thessaloniki, where he received his PhD and master's degree. He's specialized in cardiac imaging and cardiovascular rehabilitation, co-author of 85 articles in peer-reviewed journals with over 3,600 citations, member of working groups of European Society of Cardiology and Myocardial Function and Pharmacotherapy of the Cardiovascular System, and also a section board member of our journal. Next, we have Dr. Kolovu, who is a director of preventive cardiology and head of lipoprotein apheresis unit in lipid disorder clinic in Metropolitan Hospital in Athens. Her scientific interests are focused on lipid metabolism and particularly on postprandial lipemia, including gene polymorphism and efficacy of hypolipemic drugs. She received multiple awards throughout her career. Lastly, the award for Hellenic Cardiac Society for her book Andropause, Menopause, Somatopause, and Cardiovascular System, wrote 27 books and has 342 entries on PubMed. Our second speaker is Dr. Florentin, who received her biology degree from the Aristotle University of Thessaloniki and PhD in medical genetics from Glasgow University. From 88 to 96, she worked in the genetic unit of the pediatrics department in Athens University, and from 95 she took upon the organization's establishment and direction of Alpha Lab Molecular Biology and Cytogenics Center. She has many scientific roles and is a member of European Society of Human Genetics, also representative for Orphanet Greece, and is the EMQN representative of Greece. And lastly, we have Professor Rezei, who received his pharmacology degree and PhD in toxicology from Mashhad University of Medical Sciences. A lot of publications since his graduation is in mostly prestigious journals in the field of pharmacology and toxicology. Also, he's a European registered toxicologist and has been serving as an editorial board member of Food and Chemical Toxicology and Toxicology Reports in Elsevier, and also an associate editor of Sleep Disorders in Hindawi. So that's a short introduction from me. I will hand over to our chair, Professor Dr. Tsarouas.
Good morning to everybody. I would like to thank our host and the MDPI Publishing Group and the Journal of Personalized Medicine for organizing this webinar. Our theme for today is metabolic syndrome and cardiovascular disease. Metabolic syndrome, metabolism pathophysiology is multifactorial and involves abdominal obesity, hyperinsulinemia, and hyperglycemia. Central role to the syndrome plays the activation of the lipoprotein lipase and the inhibition of secretion of very low density lipoproteins. Atherogenic dyslipidemia is causally linked to cardiovascular disease. New evidence accumulates regarding the genetic predisposition in metabolic syndrome causation. From early studies on twins To genome-wide association studies, the genetic origin of metabolic syndrome was found to span to different genetic loci. On this background, environmental factors act. Knowledge of increased genetic susceptibility to the syndrome permits a personalized approach to treatment and prevention. Oxidative stress augments in metabolic syndrome, and NRF2 pathways are involved with pivotal role in inflammation. In earlier studies of our group since 2012, we have shown that there is an elevated telomerase activity in peripheral blood mononuclear cells in patients with metabolic syndrome, representing a consistent and persistent inflammatory state, as neutrophil apoptosis has been identified to be one of the key mechanisms to switch off inflammation. Findings suggested that there was a prolonged activity of inflammatory cells. Specifically, there were monocytes activation shown by the elevated soluble CD163 that could represent a contributory pathway in the pathogenesis of atherosclerosis. Oxidative stress and inflammation standard for treatment with natural product derivatives and phytotherapy. We have shown from 2014, I believe, in a series of articles on lycopene and tomato juice that dietary supplementation with tomato juice was sufficient to improve the inflammatory status and the endothelial dysfunction in metabolic syndrome patients, while insulin resistance improved, and there was a pronounced decrease in LDL, along with a slight increase in high-density lipoproteins. Also, in experimentary animals, we have presented our group that in high-fat diet induced hypertensive rats, uberlipidine, a sesquiterpene coumarin product produced by several ferula species, reduced systolic and mean arterial blood pressure. In the current webinar, the lipid metabolism dysfunction in the pathogenesis of metabolic syndrome will be discussed by Dr. Genovefa Kolovou, Director of Preventive Cardiology, Head of Lipoprotein Apheresis Unit and Lipid Disorders Clinic, Metropolitan Hospital, Athens, Greece. Genes and metabolic syndrome heritability will be analyzed, focusing on specific genes involved along with interaction with environmental factors by Dr. Lina Floredil, Clinical Laboratory Geneticist, Director of the Genetics Alpha Lab Genomics Center in Athens, Greece. Last but not least, specific benefits from natural products utilization in the treatment of metabolic syndrome will be presented along with molecular and cell signal regulation from phytotherapy from Dr. Ramin Rizai, Assistant Professor at the International UNESCO Center for Health-Related Basic Sciences and Human Nutrition, Faculty of Medicine, Masad University of Medical Sciences, Iran. I will give the floor to Dr. Genovefa Kolovou. Please, Dr. Kolovou, we are ready to hear your presentation.
Dear Chairman, dear colleagues, thank you very much for having me today. In next 20 minutes, I will discuss a lipid contribution to metabolic syndrome. These are my disclosures. And I will start with pathophysiology in metabolic syndrome. We know the prevalence of metabolic syndrome is estimated to be 20 to 25 in the adult population and more than 5% in children and adolescents globally. Various diagnostic criteria have been proposed by different organizations over the past decades. The main difference concerns the measure of central obesity. A cluster of risk factors for cardiovascular disease which occur together more than by chance alone have become known as a metabolic syndrome. And these risk factors include central obesity, low HDL cholesterol, high triglycerides, high blood pressure, insulin resistance, and glucose intolerance. And the diagnosis is clear when at least 3 of these criteria are met. In attempt to unify criteria, several major organizations met and produced harmonized definition of metabolic syndrome. And as you can see, they were organizations as National Heart, Lung, and Blood Institute, American Heart Association, World Heart Federation, International Atherosclerosis Society, and International Association for the Study of Obesity. And according to the terminology, during these decades of the metabolic syndrome, they have different names: syndrome HE, insulin resistance syndrome, metabolic syndrome, deadly quartet, drop syndrome, multiply metabolic syndrome, dysmetabolic syndrome, cardiometabolic syndrome, and most widely used is metabolic syndrome. And I will call metabolic syndrome. Dyslipidemia, which I am talking today, is the hallmark of the metabolic syndrome and is summarized as increased free fatty acid, increased triglyceride, increased small dense LDL, ApoB, ApoC3, and decreased HDL cholesterol. According to enzymes and proteins, we have decreased lipoprotein lipase, increased CTP, cholesterol transport protein, hepatic lipase, and glycoprotein called ANGPTL2. These effects are mediated via crosstalk between a multitude of pathways that promote impaired adipogenesis, adipokine dysregulation, inflammation, and increased oxidative stress, adipose tissue hypoxia and hypocity. According to glycoprotein ANGPTL2, is that if we have overexpression of it, promotes chronic inflammation, as our chairman said already. The primary defect in metabolic syndrome is abdominal fat, and this is due to environmental, biological, or inherited factors. This leads to hypertrophic adipocyte, which have the defect in incorporation of free fatty acid into triglycerides and makes that they are not trapping in the adipose tissue, and insulin resistance is adding as well, which ending up with free fatty acid increased in plasma. While they are increased in plasma, they are taken by hepatic cells and they produce triglyceride-rich lipoproteins. These triglyceride-rich proteins, they promote the changes of triglyceride with cholesterol ester between these lipoproteins and LDL on the one hand, and HDL on the other hand. And we are ending up with particles LDL with high triglyceride inside and particles of HDL with high triglyceride inside, which are very prone to catabolize by hepatic lipase. And on the end, we have small dense LDL and small dense HDL and low levels of HDL in the plasma. Besides that, the metabolic syndrome trigger familial combined hyperlipidemia, which is an inherited dyslipidemia. The prevalence is 0.5 to 2% globally, but in patients who have cardiovascular disease documented, they're about 10%, and the survivors from myocardial infarction is 40% of this. Another point with metabolic syndrome is that non-alcoholic fatty liver disease is considered to be a hepatic manifestation of metabolic syndrome, and polycystic ovarian syndrome, that ovarian manifestation. Another thing is that they can augment the likelihood of diabetes mellitus and chronic kidney disease. The main point of dyslipidemia in metabolic syndrome is hypertriglyceridemia. Normal triglycerides are serving as fuel cells for energy production and storage of excess energy in the lipids in lipid cells. And what we have? When we have dietary nutrition, they are packed in chylomicrons, and cholesterol and triglycerides from the hepatic cells, they pack to VLDL. Then these particles who are rich in triglycerides, they hydrolyze lipoprotein lipase hydrolyze triglycerides and from to free fatty acids, and these particles can go through endothelium and be taken by hepatic receptors, allowing the recycling the lipid and protein content. When we have hypertriglyceridemia, we have few mechanisms who are leading to atherosclerosis. Firstly, we have to remember that patients with metabolic syndrome, the LDL cholesterol is usually within normal limits or only mild rise. But if you have triglycerides increase, they stimulate activity of cholesterol ester transport protein, which I said before, they will have small dense LDL particles. And we now know that if we have triglycerides higher than 135, most of the LDL which measure in the plasma, they may be small dense LDL particles. And these small dense LDL particles are associated with increased cardiovascular disease because they are not cleared by LDL receptors, they have retention in the arterial wall, and they are more sensitive to oxidation and be taken by macrophages and to form cells you will see later on. And another one is that we've seen reducing of HDL, and I explained why we see it, because when we have increased triglyceride-rich lipoproteins, they mediate the CTP exchange of triglyceride and cholesterol ester, and we ended up with HDL-rich in triglycerides who are more prone to be catabolized and rapidly cleared by the kidneys, and further reducing of HDL cholesterol. You can see in this slide, chylomicrons are the big particles. They can't cross endothelium, but remnants of chylomicrons and VLDL, they are small particles because we know that most cells can degrade triglyceride, but not cholesterol, which means that they have more cholesterol inside, and they can cross endothelium similarly to LDL particles, and can be taken by macrophages from cells and be involved in atherogenics. We know now that 26% of adults, American, including the one-third of statin users, had triglycerides more than 150 milligram per deciliter. And 40% of adults with diabetes mellitus had also triglyceride higher than 150. The optimal analysis demonstrates that those with triglycerides higher than 150 compared to those with lower, they have higher major cardiovascular events, which is about 26% higher. Another issue of postprandial lipemia, of metabolic syndrome, is postprandial hypertriglyceridemia. We know that postprandial lipemia is defined as increased triglyceride-rich lipoproteins following standardized ingestion of high-fat meal, usually 70 grams fat, after an hour of fast, and blood collection over a specific time is usually 4 hours. And we call it oral fat tolerance test. That means that triglyceride levels can be performed in 3 settings: fasting, random non-fasting, or postprandially in standardized manner. We know that we all the time eating. Most individuals are truly in a fasting state for only few hours every day, and this is usually in the morning, you can see here. Thus, measurement of lipid lipoproteins in the non-fasting postprandial state reflects the metabolic status better than fasting state. What happens usually? When we eat food with high fat content, we have increased cholesterol absorption, which makes a hepatic cell to decrease cholesterol synthesis. And of course, we have insulin secretion, which suppresses the production of LDL. I have to remember you here that the production of LDL is taking 24 hours. If insulin is not working, it means that the VLDL will be all the time produced. You can see chylomicrons higher, but we have lower levels of VLDL. That means that in the artery, we have similar triglyceride, like usually levels of triglycerides. Lipoprotein lipase is working and catabolize triglyceride, taking them to the Krebs cycle and oxidize them, giving the fluid. And we have chylomicrons of remnants of chylomicrons, VLDL remnants, who are taken up by receptors from hepatic cells. But when we have postprandial hypertriglyceridemia, everything goes wrong. We are eating high-fat food, but absorption of cholesterol is decreased. Hepatic cells increase cholesterol synthesis. Insulin is not working. That means that VLDL all the time is formed from hepatic cells. That means that we have a lot of chylomicrons, a lot of VLDL. Lipoprotein lipase is not working properly, and we ended up with high triglyceride levels. It means, and happened the same as I saw it before, that means that we have triglycerides exchange with cholesterol ester in LDL and ending up with small dense LDL, and the same happened with HDL. This means similar to what I said before. As you can see, if you compare somebody who is healthy, usually have increased triglyceride until 3 to 4 hours, and after decreasing, coming back to the same level. When we have coronary heart disease, you can see we start with a lower than 150, but it goes up more than 265, and it's delay in decreasing, which means this is a typical postprandial hypertriglyceridemia. And in our study, we made about 60 papers about postprandial lipemia. If you compare triglycerides under the curve with healthy and metabolic syndrome, you see a huge difference. Now we know we classify hypertriglyceridemia as fasting, non-fasting, and postprandial. You can see the levels of when we talk about hypertriglycemia, if they are higher. And to compare non-fasting with postprandial, which sometimes the people are mixed, it's that non-fasting is random blood sampling regardless of type of meal and time since the last meal, and postprandial is blood collection at a specific time after the standardized oral fat tolerance test. According to low HDL, low HDL in metabolic syndrome is usually secondary to raised triglycerides. As I showed before, this exchange triglyceride with cholesterol ester mediated by CTP protein. And we have HDL who are rich in triglyceride and are more prone to catabolize. I explained it before. Secondary in insulin resistance. Insulin resistance may reduce the hepatic production of apolipoprotein A, which is the main protein of HDL particles, may cause the destabilization of ATP binding cassette A1, is a transporter, which is the key molecule that mediates the transfer of cellular phospholipids and cholesterol to apolipoprotein A for the formation of mature and functional HDL particles, which is very important. And of course, the transient increase of HDL. The transient increase of HDL causes the same thing which I said before, the CTP-mediated lipid exchange, formation of HDL particles as described before. That means that all of this can cause low HDL. Many epidemiological studies found that low HDL associated with increased risk of atherosclerotic cardiovascular disease. In cell culture and animal models, HDL particles show many anti-atherogenic action. However, until now, clinical trials did not find any prevention of atherosclerotic cardiovascular disease events by drugs elevation of HDL cholesterol levels, at least not beyond statins. Also, genetic studies show no association of HDL cholesterol levels altering variants of with cardiovascular risk. And it's not wonder on our decade, the HDL lost his attention, triglycerides increasing a little bit, and of course LDL is still the queen of targeting in dyslipidemia. Treatment in metabolic syndrome, the healthy lifestyle, healthy low-fat diet, weight loss, physical activity, emotional regulation, self-care, alcohol abstinence, prevention or control, diabetes mellitus, cardiovascular events, dementia, some cancers. Of course, we have to think about personalized therapies. It depends on what they have: central obesity, hypertension, hyperglycemia, dyslipidemia. It's very useful to identify the patient profile and estimate it, empowering and addressing the main or most common barriers to include therapy in daily routines. And of course, future innovative drugs, Pemafibride was very promising, but now it's withdrawn. There are some other drugs are coming. Evinocubam, I think it's right in homozygous familial hypercholesterolemia with a good results, and probably they have good results on triglycerides. We have to wait. Key points to take: dyslipidemia. Dyslipidemia means that we have increased triglyceride pool due to the production of triglyceride increased and decrease of clearance. And all this leads to increase in triglyceride, leads to increase apolipoprotein B100, increase to remnant lipoproteins as chylomicron, remnants IDL and VLDL, small dense LDL, and low HDL cholesterol. We have to remember that hypertriglyceridemia in metabolic syndrome are increasing the atherosclerotic cardiovascular risk. Most effective treatment, as I said before, is lifestyle changing, fibrates, niacin, and omega-3. And we are waiting for new therapies based on newly identified targets in triglyceride metabolism and now are developing, and we are waiting for clinical trials to prove it. Thank you very much.
Thank you, Dr. Kolovu. It was an excellent presentation from a well-known expert in the field of lipid metabolism. I would like to ask you one or two questions. First of all, I am thinking that despite the evidence that there is for a causal relationship between hypertriglyceridemia and cardiovascular events, there was not a meaningful reduction in the major adverse cardiovascular events in the most recent trial, like the prominent trial, in which patients with diabetes, insulin-resistant patients, there was a significant reduction in triglycerides, but there was not a meaningful reduction in MACE. So what is the missing link? Where could there be the problem for not achieving the trial goals regarding MACE?
Yes, you're right. Very good questions. You're very right. They decreased triglycerides about 26% and VLDL as well, ApoC3 as well, but increased apolipoprotein B about 5%, which this may be a big problem. And another problem is that fibrates can enhance lipolysis of triglycerides, lipoproteins, but are much less effective in decreasing hepatic VLDL synthesis. Maybe these two make a lot. Another thing is what I'm thinking that triglycerides, they are particles, very variable particles, and why it's very difficult to catch them. Maybe we need other drugs and wait for specific drugs acting in triglycerides.
That since the small dense LDLs can, along with the VLDLs, can enter in the arterial intima, they are atherogenic.
Yes, and have in mind that small dense LDL, they have more ApoB than other particles, native particles. Maybe is one reason why we haven't seen any improvement on cardiovascular outcome.
Okay. The second question is rather easy for you. On average, what can we expect from starting treatment regarding the reduction of plasma triglycerides and remnant cholesterol if we start with statin treatment?
Yeah, statin can be very powerful in decreasing triglycerides, especially the one who are very strong statins, like atorvastatin and rosuvastatin. They can decrease triglycerides in the high doses of this, even 30 to 40%. The statins with lighter, they can decrease triglycerides 20%. And of course, remnants. Yes. There's a lot of studies, and especially we are now writing the paper about postprandial lipemia and statin with you, of course. With you, of course, we started writing it, showing that the statin is very good in decreasing postprandial hypertriglyceridemia as well.
Okay, and I've seen in the latest publication of the European Heart Journal that in this publication, using data from the Copenhagen General Population Study, that remnant cholesterol and triglycerides were associated with at least twofold increase in cardiovascular and all-cause mortality. So I think, what do you think actually? Are new trials needed for new drugs, especially lowering the risk deriving from triglycerides and remnant cholesterol?
Yes, that is a very good question. I remind you that in the particles, only triglycerides can be catabolized. It means that all remnants, they have more cholesterol, which means that they're involved in atherogenesis. When we decrease triglycerides, they are already out from remnants. Why we don't have the good results? We have to focus on remnant on hypercholesterolemia and trying new trials to see if it's working. And Copenhagen study have very big follow-up, about 28 years. It's working. Noderstad-Borg, my colleague, is working there and show beautiful results. And concerning the concerning postprandial hypertriglyceridemia, concerning the remnant cholesterol, which is very important, and it's a different way of thinking. And it's nice we talk about it now.
Thank you very much, Dr. Kologu, for the excellent presentation. I will give the floor now to Dr. Elena Floredin. Dr. Floredin, we are ready to listen to your presentation.
Thank you very much, Professor Tsarouchas. Thank you very much for inviting me to give this talk. And thank you very much, the journal, for accepting me to give this talk. It wasn't an easy subject to start with. It's a complicated subject to discuss the genetic aspects of metabolic syndromes and cardiovascular implications. It was a challenge that challenged even my cats in the middle of the night, who couldn't bear me working on a computer until 4 o'clock in the morning. But there you go. I couldn't start this talk before giving a brief history of how we ended up to be able to read and explain so many interactions between genes and disease. It's all started early in the 1950s, but it was in the 1990s that the Human Genome Project was launched, and the first FDA approval of a personalized medicine. And in 2000, when our genome was fully sequenced and the first targeted therapies for cancer basically started, and the industry pipeline turned its head towards the potentiality of personalized medicine on an everyday basis. Oops, that doesn't work. Why? But we didn't need only that. We had to wait. Excuse me. Do apologize. Yes. Okay. But it wasn't enough. The next step was to sequence 230,000 human genomes so that we can see the differences that exist between individuals that are normal and between different ethnicities. And then we have to explain a few things because we will need it in the following of this talk. Genetics is the study of specific individual genes and their role in inheritance. And in medicine, genetics is historically applied to the study of rare single gene disorders. But now things have changed. Genomics is the new word, and this is a study of an organism's entire genetic makeup and its interaction with environmental or non-genetic factors, including lifestyle. And this is applied to mostly to common and complex diseases, such as cancer, diabetes, heart disease, hypertension, asthma, etc. There, we needed a change in the equipment we were using and the technologies. And next generation sequencing shifted everything. It shifted everything because now we don't really have to sequence one gene. we can sequencing thousands of genes together, and with the use of bioinformatics, we can analyze many genes together. Then we realized that 20 and 30% of our lifespan length is determined by genes. Quite often people ask me, what can genetic tests help us to do? To diagnose our disease, to pinpoint genetic factors that cause our disease, predict how severe our disease might be, choose the best medicine and correct dose, discover genetic factors that increase our disease risk, find genetic factors that could be passed to our children or be inherited by our parents. And the last one, that's not the topic for today, screen newborns for certain treatable conditions. This changes the face of medicine. It increases opportunities to prevent disease, to direct the selection of optimal therapy for each individual, to help avoid adverse drug reactions, improve methods of administration, improve quality of life, increase treatment options for the benefit of our patients. I had to discuss with you the monogenic feature of cardiovascular disorders before I go into the metabolic syndrome, because we really have to make a difference of it. We know we have the coronary artery disease, we have congenital heart disease, we have inherited arrhythmogenic diseases, and cardiomyopathy. And the last three are congenital abnormalities. And we know that there are genes related to primary familial arrhythmia syndromes like long QT, Brugada, catecholaminergic polymorphic ventricular tachycardia, and structural cardiac diseases with arrhythmia that cause cardiomyopathies, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, familial dilated cardiomyopathy. And their inheritance is usually autosomal dominant, which means you have a gene, you have a defect, a mutation, a variant. This is a new way of word that we use for mutation. And most of them are inherited, and we inherit it to our children. But a small percentage are de novo, which means they appear on one individual without family history. And now we can see that the prevalence of atrial arrhythmias in inherited primary arrhythmia syndromes is quite important. Long QT syndrome is 4 in 10,000, which is the 2% of atrial arrhythmia rate. Brugada syndrome is 1 in 2,000, which is 20% of atrial arrhythmia rate. So we have to think of monogenic disorders and cardiovascular diseases. And there are a group of genes that one can test these days and have a diagnosis that can help the patients and shift the patient's therapy and be precise for their syndrome, for their condition. And some cases which are not as clear-cut as, for example, some long QT cases, an example I give only, can use large panels of cardiovascular genes and look at different genes, because now we know that there is a synergic action between different genes as well. And now we go to what we call CAD. This is the result of hypertension, diabetes, obesity, and these are determinants that have a genetic variance involved in this, and the non-genetic variants like age, smoking, etc. The inheritance in these cases seems to be, according to new data, up to 50%. And therefore, we have monogenic risk variants. Monogenic risk variants are rare. They have to be in the general population in a percentage below 1%, and are typically really bad mutations that confer a large risk of the disease. And monogenic risk variants follow classic Mendelian patterns of inheritance. For example, it is due to monogenic risk variants in the LDL receptor ApoB and PCSK9 genes that affect that cause familial hypercholesterolemia, which is all these Greek words that I have to use in English makes it difficult. A monogenic disease that causes severe hypercholesterolemia and a significant risk factor for early onset myocardial infarction. Other examples of monogenic risk variants include GCK for diabetes, KCNQN for atrial fibrillation, and factor V for venous thromboembolic disease. But as you can see, all these genes intercalate and come together in the metabolic syndrome as well. And there aren't only these genes. One of the most common genetic diseases in mankind is familial hypercholesterolemia. And it is typically an autosomal dominant disease, which means that if I carry a gene that has a mutation, then I have the risk of having elevated levels of low density lipoprotein and a result to premature CAD and myocardial infarction. But strikingly, if left untreated, 50% of men and 15% of women with FH will succumb to the disease in their early years. The heterozygosity, which means carriers of FH, is 1 in 250 persons, and this is quite a percentage. So look at this. Now we have FH and 3 major genes. Most of the mutations are found in LDLR, and this is the main cause of the disease. And we have ApoB, and we have PCSKN. 5% of CAD patients below 60 years of age have an heterozygous mutation in the LDLR gene. And we can see that if you are a carrier of LDLR gene, your CAD risk is highly elevated. But if you have certain kind of mutations in the PCSK9 gene, first, you can change the therapy. Second, some mutations have a protective action that lowers the LDL cholesterol. So it's very interesting, that part as well. But there aren't only these monogenic contributors to CAD. We have other genes that are being tested just now. And we have realized that by studying different populations, and we will come to this, we find that there are mutations, variants in different genes that all of them together can be the cause of 15% of FH, which means I can have different mutations in different genes related to hypercholesterolemia that explains 50% of this disease. And then we have quite a few genes for type 2 diabetes. So we have a predisposition for that too. And there are lots of tests being done concerning this. And we come to metabolic syndrome, which puts together a lot, that and a lot more than this. As Dr. Kolovou said, METS as a syndrome X has got 5 factors: hypertension, obesity, hypertriglyceridemia, hyperlipidemia, hyperglycemia. And if you have 3 of those risks, you have METS. And then on top of this, you have age and not enough exercise. The genetic susceptibility stands on genes related to all different kinds of these entities. And we have, the literature has shown that there is a different prevalence depending on geographic, racial, and ethnic origins for METs, the prevalence being 35% in North America, 11 to 26% in Europe, and 12 to 37% in Asian Pacific region. You can say that this has to do with their eating habits, but as I will show you with some other genetic factors, ethnic analysis, racial analysis for genetic variants is important. These clinical features of METs are caused by genetic factors in about 50% of cases. And I will show you some of the genes that are related to the metabolic syndrome. There are central obesity genes, hyperglycemia genes, hypertriglyceridemia genes, low HDL cholesterol genes, and hypertension genes. And this paper that is in Korean population has decided to target all these genes together in a group of patients and see if they find new genetic variants that are pathogenic and could be the cause for their metabolic syndrome. But I think I did not put yet, there were about 3 different slides with combinations and different pathogenic mutations. There are a lot of pathogenic mutations. I won't discuss the variants of unknown significance because we find this study identified 84 variants related to the 5 clinical features of meds. Among them, 50 variants identified are novel ones that may be related to clinical features of meds. The results suggested that the candidate genes and rare non-synonymous variants related to the 5 clinical features of meds may be used as potential genetic variants or molecular predictors of meds. However, additional studies in different ethnic populations and functional studies are needed to validate these variants. So are only the monogenic variants that influence disease, or are polygenic risk variants as well? And listen to me, when I'm talking about monogenic variants, I can tell you about multiple monogenic variants that they can affect and lead somebody to the metabolic syndrome or cardiovascular disease. But there are also polygenic risk variants in terms of what we call today PRS, and I will explain in a minute what PRS are. What we have found is that it became as an observation that people who are carriers of your mutation in the LDL gene, which is a monogenic risk variant as a disorder, have different cholesterol concentrations despite the fact that they have a pathogenic mutation. And their risk for developing CAD is not the same for all carriers. This variation was aligned with each person's PRS, as I will explain. That is, those with a low LDL CPRS and carriers of familial hypercholesterolemia, on average, have a lower LDL-C and a lower risk of CAD compared with those with a high LDL-C, PRS, and monogenic and carriers of familial hypercholesterolemia. This concept has also been extended to cardiomyopathies. For example, the risk of developing hypertrophic cardiomyopathy depends on monogenic risk variants and a person's PRS. These observations support the liability threshold model. That is, the notion that multiple factors, monogenic, polygenic, and non-genetic, may each contribute to a threshold necessary for disease development. So, what are we talking about? Being able to predict an individual's risk of common conditions is regarded by many as the Holy Grail. Where are we now? Many of the serious health problems we now know that it has a multifactorial inheritance. This means that other than being the result of a single gene variant, monogenic variant, they're influenced by a large number of genetic variants and environment. And this genetic variation that we all have has been used to make the polygenic, to invent the polygenic risk scores, PRS. This genetic variation is what we all carry, and through the human genome 230,000 sequencings that have been done, they've noticed that there are a lot of single nucleotide polymorphisms, SNPs, that are individual nucleotides that are different amongst individuals that have nothing to do with a disease. A SNP is the most common type of genetic variation that exists, and we each carry millions of those. However, can these genetic variants be associated with common disorders? The first genome studies conducted in 2005 compared 96 patients with age-related macular degeneration with 50 health controls. And they identified 2 SNPs with significantly different allele frequency between the 2 study groups. And they used these SNPs to predict who are in the high risk group to have to develop age-related macular degeneration. This has been used in cancer, in CAD, and now it starts to be tested and used for metabolic syndrome. Statistical geneticists, therefore, have developed the polygenic risk score, PRS, identifying hundreds, thousands, and even millions of SNPs that can be included in a single score that measures the individual's genetic predisposition to specific diseases or threats. PRSs are often expressed as a risk percentile. In individuals with a PRS close to the population mean, the person's predictive genetic risk will be similar to the population's risk, but a person with a PRS in either the 91st to 100th or 10th percentile of a population would be considered to have the highest and lower genetic risk respectively. And this is the curves that we'll start to get used to, how we will separate with SNPs, low risk, intermediate risk, and high risk, and incorporate these together with monogenic genetic defects to give new risks for developing a cardiovascular disease and a metabolic syndrome to the general population and to patients. For example, two different kinds of genetic tests with a monogenic driver of risk in familial hypercholesterolemia, a carrier of one of these of mutations in one of these genes has a fourfold increase of CAD and therefore needs targeted therapy to reduce LDL cholesterol, PCSK inhibitor, etc. And if you are a carrier of LPL ApoE5, you have a twofold increase and there you change and you need a different kind of therapy. And if you are a carrier of lipoprotein L, LPA, then you have a fourfold increase and you need to get the therapy for lipoprotein A. But if you use a genetic risk score, a PRS, this is an example that did, 1 in 5 prevalence have a twofold increase in CAD, and these have to change their lifestyle. The therapy, pharmacotherapy may have to start earlier, as screening for subclinical disease may have to start earlier. However, genes are not our fate. Studies have revealed that even if a person is shown to have a high genetic risk to adverse cardiovascular outcomes, by changing things, they can change their lifestyle, they can change their therapy, they can remain healthy. There are a lot of challenges when somebody uses polygenic risk scores in opposition to the monogenic factors who are definitely pathogenic. Is that a high score does not mean that the person will definitely develop the condition, or a low score that it will not. And it cannot replace appropriate for disease screening. And it needs, of course, an informed consent, and you have to explain to people what this test does. And especially there is a difficulty that the accuracy of a polygenic risk scores, it depends on the ethnic group that has been tested. And therefore, if somebody wants to make a polygenic risk score for cardiovascular disease or metabolic syndrome in their own country, they have to develop their own polygenic risk score after doing a lot of research. And it is important for the meds to be studied in specific populations. Let's have a look at that, which was an example of how they used cardiometabolic, they used information with genes, monogenic, and PRS. They found that the very the persons that were in high risk had a high PRS and monogenic disorder. And there were the high polygenic score, the intermediate, and the low polygenic score. And half of the participants with CAD had a change in the management that fell into two categories after this analysis that they did. First, there were changes in pharmacotherapy, included the prescription of specific medication to prevent or delay CAD. And second, there were diagnostic coronary imaging scans to access for existing coronary plaque. And those that did not have a background, that did not have CAD, had to change this was a test between people that had CAD and people didn't have CAD, and they did all their tests, and they figured out of those who had CAD, who were the really high risk or who had to change their medication or follow up because their risk was getting lower because they didn't have high monogenic variants, a high risk, and they didn't have a high PRS. So they defined better those who had CAD, in which group they were, and they altered their medication. And those that didn't have CAD, but they had risk because of monogenic variants and high PRS, they had to change their management and start statin or start a different follow-up. Obesity. Obesity, I have to finish, it finishes anyway. Obesity is one thing that has to do with PRS as well. And despite the fact that there are specific genes for obesity, they did in this paper, which a polygenic prediction of weight and obesity from birth to adulthood, they found that a genome-wide used thousands of SNPs. Polygenic score can quantify inherited susceptibility to obesity, and a polygenic score impact on weight emerges early in life and increases into adulthood, and that the impact of polygenic score in this paper was similar to a rare monogenic obesity mutation. And high polygenic score is a strong risk factor for severe obesity and associated disease or coronary diabetes, hypertension, heart failure, ischemic stroke, and venous thrombosis. And then that was working in practice in a cardiology clinic, which decided to do a test with variants in 158 genes that are related to cardiovascular disorders, to cardiac syndromes as the ones that I have told you before, and to hypercholesterolemia and other factors. And they found that in all the cases that there were pathogenic variants, they changed the medication. They related the specialist, they referred the specialist to the patient to another specialist. They changed the follow-up. It was very important, the test that they did. See, for example, they found by accident a Marfan that had to be switched to a different specialist. So this was a very, very important there in the LDLR. They found lots of cases that had to do medication change and referral to a new specialist. So that was a very important finding. And their conclusion was that a comprehensive molecular assay combining both rare, high impact genetic variations and common susceptibility markers in the form of PRS, RPA polymorphisms and pharmacogenetics alleles can be used, and more than 30% of the cohort patients were found to have a positive finding with potential clinical impact even after excluding pharmacogenetics finding present in nearly half of all patients. And physicians also found these results to benefit patient health and improve clinical care, with 84% reporting medical management changes in those testing positive. I will not proceed further. I will just say that by diagnosing the genes that were related to familial hypercholesterolemia, they changed the medication that they used. And it seems that insurance payers, the insurance companies demand to know if to know if a patient is a carrier of certain genes, but they don't cover the cost to do these tests. So there is a lot that has to be done on the insurance side of things as well. So here we see that if you know that you have a mutation in PCSK9 inhibitor, you need to change the therapy. And several individuals with a pathogenic variant in LPL were identified and this is a gene associated with severe hypertriglyceridemia and pancreatitis. And in addition to lifestyle and diet changes, these individuals are candidates for aggressive triglyceride-reducing therapy with a combination of fibrates, niacin, and/or fish oil, with newer therapies under development using antisense and small interfering RNA approaches, which are effective in individuals with loss of function variants in LPL. So what is current knowledge to finish? The use of genetic tests is central to personalized medicine. The role of genetic counselors and the role of the medical doctors who have to understand Mendelian disorders and the interaction between genes and environment is important. So education is important. The interpretation of genetic information in complex diseases is difficult, and this must be a multidisciplinary team that works on that. The volume of genetics tests will outstrip traditional counseling resources, so counseling has to change. What is new is that the complexity of subspecialty medicine requires subspecialization of counselor training, organized approaches to address risk, ethics, and communication between the provider and patient, and the role of genetic counselors for complex diseases must be updated so that we can be more efficient to our patients. So it's true, genetics is here. Maybe it's not our destiny, maybe it is, but we can know lots of things about our future and change it. And a glimpse into the present, I would say, is that the doctor sits in his office, opens the internet and looks at the new data concerning diabetics, looks into the genomic profile of his patients and chooses those for whom this latest genetic information could make them good recipients of a new therapeutic approach, and others that by changing their way of living, they would reduce their risk of developing the disease. He picks up the phone and calls them. What that means is that we do the genomic profile of our patients in the near future, and we keep it as we do for a lot of our patients these days. And every time that something new comes up, we go back. You need us geneticists to do that, that is true. We go back, reanalyze, and come up with new data for your patients. Thank you.
Thank you very much, Dr. Florentin. It was an excellent presentation. I understood from what you said that in familial hypercholesteremia, we should make a genetic check.
Yes.
It is mandatory by now, I think.
Yes.
And the second, the second thing is how easy is to perform the polygenic risk score? Is it easy? How many days of laboratory work per person would be needed for make the polygenic risk score on average? It's something easy or it is something difficult?
When you research it, it is something difficult. When a product comes up, which means a combination of SNPs that is available for each population and useful, no, it's not difficult and it's not expensive anymore. But at this moment, I don't think that the majority of the populations are ready to use PRSs for specific diseases. It's mostly on the research basis. Some people are offering it in private services, but we have to be really careful. You cannot use a kit or a test that was developed in Korea, for example. They're very good in their science, but it is the Korean population that has been tested, or in America, it has to be specific for the population that it will be used. On the other hand, the monogenic traits like familial hypercholesterolemia and the syndromic and non-syndromic cardiomyopathies, arrhythmias and things are not specific to the population. We use the data of the population, but they are not specific. It's specific for the gene and the variant that you find and you characterize.
Thank you very much. Very impressive presentation. Now I will give the floor to Dr. Ramin Rizai to talk for his presentation on natural products and metabolic syndrome. Dr. Rizai, we are ready to listen to your presentation.
Good morning to you and all the audience. It's a great pleasure for me to be among you. I would like to thank you and thank the publisher for the invitation, and I hope I can share you something interesting. Okay, now let's start with the value of natural products in cardiometabolic medicine, how they are acting in this field, what are the recent results, how we can count on them for development of new candidates. Honestly, the use of traditional medicine, and specifically with the naturally occurring compounds, in my eyes, is a double-edged sword. I mean, we have some knowledge, we have a lot of data from the history, from the historical use of them, but also we are facing a great number of compounds, and even worse, the mixtures, the extracts that should be evaluated in terms of modern science, to evaluate their efficacy, to evaluate the adverse effects, and especially the outcomes of chronic exposure to them. As mentioned by dear colleagues, you know now the definition of the metabolic syndrome. It is also known as the deadly quartet because of these changes. I mean, the appearance of obesity, having a glucose intolerance, and hypertriglyceridemia, and hypertension. Metabolic syndrome, unfortunately, confers increases in the risk of diabetes mellitus, cardiovascular disease, stroke, MI, and the mortality of such events. There are different definitions for the syndrome by different bodies, authorities, but okay, they share some common points, and the limits and the ranges are almost very close to each other. Generally, the visceral adiposity would lead to increased reactive oxygen species, oxidative stress status, also the increased function of RAS, and then the increased inflammatory status with increased levels of leptin, chimerin, and decreased levels of adiponectin. These all actually contribute to chronic inflammation, hormonal changes, and insulin resistance. All these would also contribute to diabetes development and CVDs. So the general picture is that these natural compounds are going to combat this box. I mean, the oxidative stress, the pro-inflammatory status, and the increases in hormones or decreases in adiponectin. In 2015, an Iranian team of authors actually published this, the metabolic disorders and how natural products modulate them. A more recent one by the same team was published on obesity and metabolic syndrome. In this study, they included 279 clinical trials, and they found that the plant that you can see the names here. I'm not going to read all because it would be perhaps boring. A lot of plants would reduce obesity and metabolic syndrome symptoms, and some of them, which are very commonly used in our daily diet, would reduce appetite. Especially, this meta-analysis showed that green tea can help for anthropometric indices, I mean reductions in weight, in BMI, in weight circumference, and also to reduce the cholesterol levels. Bacillus vulgaris, which is the common bean you see here, and Nigella sativa, which is also known as the black seed, you can see here, they also showed improvement in the weight for the bean and the lipid profile for the black seed. This review article focuses on suppression of appetite, suppression of inflammation and lipogenesis, and also improvement of the insulin function, as well as repression of the lipid absorption through the GI. So various plants are differently acting in our body to alleviate the metabolic syndrome symptoms. For the changes in the hormonal levels, some plants were shown to actually induce the level of GLP-1, some of them to reduce the levels of adiponectin, and some of them to decrease leptin levels. To suppress the pro-inflammatory status, C-reactive protein could be decreased by some of these plants extracts, TNF-alpha, and also interleukin-6 by pomegranate and tea. I chose these plants out of this meta-analysis because most of the trials are focused on these plants. So from the left up to the right bottom, you can see from green tea to the bean here. And as you see, green tea is a commonly discussed one. I mean, a lot of trials have been done on it, and various parameters from the glucose and lipid profile, as well as the anthropometric indices have been evaluated for green tea and Nigella sativa. This is also an interesting study. Okay, it was published more than 10 years ago, but it is still interesting. And I included it here because of the first row, cinnamon, which I'm going to present the clinical trial we had in cinnamon. So I thought that maybe it's interesting to show that cinnamon is known for improving the insulin function, reducing blood sugar level, reducing blood pressure, and alleviating the high levels of triglyceride and LDL. Another issue is that in some cases, naturally occurring compounds and the herbal extracts are not used even in the extract form, which is itself a huge mixture. And in some cases, we are facing polyherbal combinations, and they are commonly used in some traditional practices. So I just wanted to mention this. I'm not going into this because it's very difficult to discuss the effect, but this is a very recent and very nice presentation of polyherbal combinations. What is attracting more nowadays is the isolated compounds, the compounds that are secondary metabolites produced by the plants. They have various different activities, pharmacological activities, and that's interesting for the industry and for the scientists. One of them is berberine. Berberine is produced by Berberis vulgaris, which is a very common plant used in Iran, for example, in my country. It was shown to improve the actually the glucose profile, in some cases the lipid profile, and also to combat the pro-inflammatory status by reducing downregulation of COX-2 and prostaglandin E2. Also, another famous one is the curcumine and the curcuminoid. They are also known for their antioxidative and anti-inflammatory effects, both of them contributing to reduced chances of all symptoms that we know are parts of the metabolic syndrome. Curcumine actually has shown some effect in diabetic people, diabetics who had higher levels of blood glucose and HbA1c, and a worsened situation of lipid profile. But actually, this meta-analysis showed that it's not effective in patients who don't have a diabetes profile. And also, no effect was found on systolic blood pressure or HDL-C. The only very important point about curcumine is the bioavailability, that curcumine suffers from a good bioavailability. It doesn't have one, so a lot of nanomicelle preparations are in the market or in the process of being produced or in research phase to increase the bioavailability of this very interesting compound, the curcumine. Another interesting compound is resveratrol. It is found in great seeds. So a huge number of studies have been done on evaluation of resveratrol compound effects in various models. Resveratrol was shown to actually change the SIRT1 and MDPI activity. Generally, it is known to activate the pathway, leading to enhanced function of NRF2 and the antioxidant activity. One of our, let's say, recent studies was an RCT on cinnamon. We checked if cinnamon treatment for 3 months, 90 days, could change the blood pressure profile, lipid profile, and FPS in actually patients with stage 1 hypertension. We gave the patients 3 times a day capsules of 500 milligram cinnamon, so it's a total of 500 milligram per day for 3 months, and the other group received placebo, identical in shape and appearance. We included 40 patients, or 2 in each arm of this RCT, as you see, and we analyzed 18 and 19 in these 2. This shows how cinnamon for 90 days treatment would change the lipid profile and the glucose levels. This is the 0 baseline data, let's say, up here, and this shows the difference between the groups on the day 0, and this is at the end of a determination of the trial, and it shows the changes between the groups here, and also this p-value shows differences between the cinnamon groups actually on day 0 and 19, and the last column is for the placebo comparison between day 0 and day 19. Also, we checked how it affects the systolic blood pressure and diastolic blood pressure and changes the BMI. Generally, we found that, as you see here, we found that cinnamon has a good effect on the lipid profile, as we already knew, but okay, not very significant changes in the blood pressure we observed. In an in vivo study, also we checked the effect of ombleprenine in blood pressure in high-fat treated rats. Ombleprenine, as a prognostic Kumari, was given to rats, and these rats were actually treated with high-fat diet. This high-fat diet was supposedly going to induce some changes in lipid profile and the blood pressure. Here you can see that the control group on the very left side, which was treated with the normal diet, and from the second column on the left to the right column, to the most right actually, they are all treated with high-fat diet, and this goes for this figure also. For systolic blood pressure and diastolic blood pressure, we found that this high-fat diet could induce the pressure. Okay, it was significant for the systolic, but not significant for the diastolic. And the high dose ombleprenine could reduce systolic blood pressure compared to the high fat control significantly, but it was not significant for the diastolic blood pressure. For the mean arterial pressure, the same. We observed that the highest dose of ombleprenine will reduce it significantly compared to the high-fat diet control, but we did not find significant changes in heart rate among different groups. And this is the general conclusion of this study. Also, we checked crocin and hesperidine effects on hypertension in a similar model of high-fat diet treated rats. Crocin is an interesting compound, because actually it is why we see this red. I mean, this is the coloring agent of saffron, Crocus sativus, which is regarded as the most expensive spice all over the world. It has attracted the attention of the scientists for more than 2 or 3 decades now, even the isolated compound crocin, not only the saffron extract. And it has shown various effects. In a recent review, we discussed how crocin modulates pain and inflammation, and regarding inflammation, which is actually let's say cornerstone of this syndrome, we found that crocin can modulate the PI3K and AKT pathway and regulate the NF-kappa B pathway as well. So all these, along with the good promising profile of hesperidine, motivated us to check how these two agents can change the blood pressure in high fat diet treated rats. For hesperidine, also it was shown that it can reduce hypertension in hypertensive rats, not the non-intensive ones, and we have some evidence on this. Okay, a recent meta-analysis also showed that despite all the preclinical evidence, hesperidine has no effect on the systolic blood pressure or diastolic blood pressure. So we checked crocin alone, hesperidine alone, and hesperidine crocin combination here in this group on the same model as we talked about in ombliprenin. Here we also found that systolic blood pressure was changed significantly compared to the normal control rats, and the heart rate remained unchanged. But treatment with hesperidine and crocin and hesperidine alone could compensate what happens here and reduce the systolic blood pressure, but crocin could not do it. So it was actually, it could reduce, but statistically it was not significant. In case of heart rate, the combination therapy with hesperidine or crocin reduced heart rate. For the diastolic blood pressure, we did not see, despite these increases, we did not see statistically significant changes among the groups. And for the map here, we found increase compared to the normal diet and a decrease when we co-treated with hesperidine and crocin together. All these evidence shows that, okay, there is promising data concerning the use of natural products in metabolic syndrome, but we should consider that our knowledge is not supported by a great number of publications. So we need more evidence in this regard, especially when we are going to use them as chronic medications, for example, in the case of metabolic syndrome patients. So we recently published this chapter in this book. You can see the name, the toxicological risk assessment. So we discussed the safety profile of plants. As you see here, according to the WHO, 80% of the Asian African population they have a tendency to use traditional medicine, and also in the US, and let's say an old survey, it was like 20 years ago, but it shows that 20% of the adults are using some supplements that involve an ingredient which is naturally occurring in the hair. Generally, the general belief is that all these natural products are safe, and there is a positive attitude toward them. So this can be a good point, but also before gaining enough evidence, it can be harmful for the general public. For example, here you can see that in Africa, there are 5,000 plants being commonly used in complementary medicine, alternative medicine. So these need to be supported by modern scientific data that they are harmless for people, especially in chronic exposure. And these three words are very important when you are talking about traditional medicine using the herbal compounds: accessibility, acceptability, and the affordability. Actually, the first two, the number one, accessibility, and the number three, affordability, is very important, especially in case of the low and middle income countries. Acceptability, okay, is a general point globally, but 1 and 3 is very important. That in some cases, in some countries, they are taken more because of actually being more in excess and being less expensive than the conventional treatments. One of the main points that I want to highlight here is that we have, despite all these evidence, we have limitations when we are talking about phytochemicals. Most of them are used and examined in the form of extracts, mostly. But recent data on isolated compounds are very interesting. But the point is that when we are talking about extracts, we should consider standardized and characterized extract, because variations in the cultivar and growth conditions would change the composition and the percentage of the level concentration of the active compounds that may significantly affect the outcome of exposure. So maybe you cannot see what has been seen, for example, in China using the same plant when you're doing this in Iran or in Turkey. So this should be considered that characterization and use of a standardized extract should be actually a part of all these trials. But in most of the cases, you cannot find this data in the published articles. Another point is that when we are comparing the isolated compounds, active compounds, and the extracts of the natural products, and how we attribute the effects to specific compounds. Also, clinical trials comparing against placebo should also consider to run trials to compare the effects compared to conventional treatments and the use of natural products as an adjunct therapy. I mean, not depriving some patients from the normal therapy, but adding the herbal product to the conventional therapy. So as a co-treatment, and then evaluate the effects. We do need more data on potential interactions, food and drug interactions with the natural products. And as I emphasized several times during this speech, we do need studies on chronic exposure to these chemicals or to these herbal extracts when we are talking about treatment of chronic diseases, to make sure that even exposure to low levels, low concentrations of these compounds would not cause harm to the general public. Thank you very much for your kind attention. I hope it was not too long or boring for you. And okay, this is a great piece of my motherland, Iran. This is Persepolis, you know better. And I wish you come and see it once in your life at least. Thank you.
Thank you, Dr. Rizai. It was an excellent presentation, very informative. A question from my part is, as I understood from your presentation, there is specific pathways that are targeted by the natural products. Possibly they could reduce arterial blood pressure, but this can be done by weight reduction, or do you think by targeting specific pathways like the ACE pathway or the NRF2 pathway? It's primarily weight reduction that leads to hypertension, arterial blood pressure reduction, or it's specific pathways that are targeted?
Thank you for your question, and thank you for your kind words. Actually, the point is that I was reading an article on NRF2 some days ago. It was very interesting for me that a group from the US, they discussed that, okay, even when we are talking about NRF2, we are not talking about a single pathway. When we are talking how a compound is modulating NRF2 pathway, there are several downstream, upstream cascades related to the NRF2. So NRF2 also has a dark side. And this special term, the dark side of NRF2, was used in their article, and they emphasized on this concept. For your question, actually, it could be both, but for sure, as we discussed here in the presentation, there are various pathways that are targeted by the natural compounds. But when we are discussing results from the clinical trials on extracts, I mean, not isolated compound, it is super difficult to attribute desired or undesired effect to a single compound and a single target. Because the mixture, you can assume hundreds of compounds are existing in a mixture, in an extract.
Thank you very much, Dr. Rizai, for your presentation, for your excellent work. You have a very impressive experimental work. As conclusions of this webinar, I will sum it up for all the speakers. We have learned from Dr. Kolovu that in metabolic syndrome, there's small dense lipoprotein particles, especially when triglycerides levels are above 135 milligrams per DL. The metabolic syndrome is linked to non-alcoholic fatty liver disease, and that useful information come also when we measure non-fasting triglyceride levels. From Dr. Floridine, we have learned about the monogenic and polygenic heritability of metabolic syndrome and its components, that we should check that in our daily practice, the genetic testing in the form checking the familial hypercholesterolemia, and also that 50% of the cases of metabolic syndrome have a component that comes with genes, that there is a heritability. And that polygenic risk score is the future regarding the evaluation of metabolic syndrome and cardiovascular disease. And from Dr. Rizai, we have learned that herbal medicine affect the metabolic syndrome, that herbal medicine can reduce weight and inflammation. And there is a lot of work to be done in regard in characterization of the products and their safety. Despite that, from the animal work, from the experiments in the animals, we have seen that specific natural products can suppress pathways like the sirtuin, can activate pathways like the sirtuin expression. But in any case, herbal products can be used, but with extreme caution and with always with the advice of a doctor. I should thank the MDPI Publishing Group and the Journal of Personalized Medicine for organizing this webinar. To all speakers and attendees, I wish you a good day.
Yes, on the behalf of Journal of Personalized Medicine, I would like to thank our chair, Professor Tsarouchas, and all of the speakers, as well as the attendees of this webinar. I would like to remind the attendees that the recording of this webinar will be available in the link in the chat, and also you can submit your papers to this special issue and to the journal also on the link in the chat. I hope everyone has the nice rest of the day, and thank you again, everybody.
Alexander, thank you very much as well.
Thank you very much. Have a good day.